Welcome everybody to this heavy menstrual bleeding webinar, which coincides with the relaunch of the Clinical Care Standard on heavy menstrual bleeding. My name is Phoebe Hodgson-Kumara. I'm a GP working up in Hornsby, and I'm a medical advisor at the Commission on Safety and Quality in Healthcare. And I'd like to introduce you to our other panelist today, Professor Kirsten Black. Thanks so much for joining us, Kirsten. Can you tell us a little bit about yourself?
Hello, yes, thank you, Phoebe. I am a clinical academic gynaecologist in the Sydney Local Health District and Professor of Sexual and Reproductive Health at the University of Sydney.
Wonderful, thanks so much for joining us. So today we're going to be taking a deep dive into the topic of heavy menstrual bleeding to talk about why it's important to look at quality of care for women with heavy menstrual bleeding, talking about the timely recognition and assessment of heavy menstrual bleeding, offering relevant investigations, including high quality pelvic ultrasound, and then we'll be talking through 3 case studies at the end and discussing the different treatment options that we can offer for heavy menstrual bleeding, depending on the woman's needs and preferences. So if you've been watching the news recently, some of these headlines might be familiar with you. There are just so many stories published recently in the media relating to women's health issues, and I think that this is a really timely opportunity for us to revisit heavy menstrual bleeding when there's so much momentum around women's health and an acknowledgement of stigma and how entrenched systems and practices can negatively and positively impact women's experiences of care. So why do we need a clinical care standard on this topic? Well, firstly, heavy menstrual bleeding affects a lot of women. It's experienced by at least 25% of women of reproductive age and can have a really significant impact on their quality of life. We also know that 60% of women with heavy menstrual bleeding are iron deficient or have iron deficiency anemia. And also we know that across Australia, there's significant variation in the quality of care that women receive for their heavy menstrual bleeding. And so the Commission's been doing a lot of work looking at rates of endometrial ablation and hysterectomy across Australia since 2016. And I think that gives us a little window into just some of that variation in care and the importance of equity in access. So I'm just going to be handing over to Kirsten now, who's going to be talking us through some of that variation across Australia, but also looking at what's happening across the world.
Thanks, Phoebe. So before we look at the Australian data, let's look at some of the OEC data showing that Australia has very high rates of hysterectomy by international standards. While there are some limitations when it comes to comparing data across countries, it's striking that Australia's rate of hysterectomy in 2019 was more than 60% higher than that in the UK or New Zealand. So hysterectomy rates in Australia and in comparable countries have been falling. But in 2019, rates in Australia remained high, especially in comparison to those countries I previously mentioned. Just to note that this data are for both cancer and non-cancerous conditions, but we know that approximately 90% of hysterectomies are performed for benign indications. So on this next slide, we can see the hysterectomy rates and how they varied between 2014-15 period and 2021-22. We can see that there's been a 20% decrease nationally between these two time periods in the hospitalisation rate for hysterectomy, and there's been decreases across all states and territories. You can see on this map of Australia, the sections are the statistical areas, and the darker areas represent the higher rates of hysterectomy. And Phoebe, if you could just show us how it changes between the 2 time periods. The important thing to take away also is that there is, despite the fall, there still remains big variation in the rates of hysterectomy between different areas. So there is a 5-fold variation between those areas with the lowest rates and those areas with the highest rates. Thank you. Next slide. Well, the the evidence that we have for endometrial ablation over similar time periods, so 2013 to 2016 and 2019 to 2022, show that there's been a 10% increase nationally in the rates of endometrial ablation. Again, there's kind of wide variation across the country. So there is a 20-fold difference between local areas with the highest and the lowest rates of endometrial ablation. And rates were higher in inner and outer regional areas of Australia compared to major cities and remote areas. Thank you.
Thanks, Kirsten. And I guess that's in the context of us trying to say that there are so many good options other than hysterectomy nowadays. And so we're wanting to see over time that those rates of hysterectomy are dropping, isn't it? Yeah. So I guess this is just a good opportunity to talk about clinical care standards more broadly. The purpose of clinical care standards is to support evidence-based care and reduce variation in care while promoting shared decision-making between health professionals and consumers. So it's really important, though, to note that clinical care standards are not the same as clinical guidelines. So clinical care standards don't describe all the components of care, so they tend to be less detailed than a clinical guideline. And instead, they encompass a limited set of what we call quality statements that address quality improvement priorities and describe the expected care for a health condition or procedure. So it's in the context of the data that Kirsten just shared that the heavy menstrual bleeding clinical care standard was originally developed. Oops, sorry. So when we look at the heavy menstrual bleeding clinical care standard today, it's made up of 8 quality statements that describe the expected care for women with heavy menstrual bleeding. So we'll just be going through each of those statements briefly now, just to get you up to speed. So the first quality statement is around assessment and diagnosis. It says that the initial assessment of a woman presenting with heavy menstrual bleeding includes a thorough history, assessment of impact on quality of life, a physical examination where clinically appropriate, exclusion of pregnancy, iron deficiency and anemia, and that further investigations are based on the initial assessment. So I guess historically we've talked about menstrual blood loss and trying to quantify it, and we might have said 80 mils or more per menstrual cycle, but now we've moved to a definition of heavy menstrual bleeding that says that any excessive menstrual bleeding that interferes with physical, emotional, social and material quality of life is considered heavy menstrual bleeding. And really what that means is that we've just got to take a really detailed history of the menstrual symptoms and also ask about related symptoms such as pelvic pain or pressure, or looking at systemic causes of bleeding. So I think we've just got to take women really seriously when they first present to talk about these issues and be interested and be thorough in our approach. Now, just as a quick reminder, the palm coin classification system can be a good way for us as clinicians just to remind ourselves of those common and less common causes of heavy menstrual bleeding. And those are categorized into structural and non-structural causes. When we talk about investigations as part of that assessment and diagnosis process, the assessment should usually include a physical examination that would include a bimanual pelvic examination, exclusion of pregnancy if that seems relevant, and other investigations would depend on your assessment. So that might include thyroid function tests, cervical screening test, STI and ultrasound. The second quality statement is around informed choice and shared decision making, and obviously just to say that that's important in everything that we do. And women, particularly when it comes to heavy menstrual bleeding, I find as a GP, do tend to have preferences, beliefs or thoughts around what treatments they're interested in pursuing. And we've also heard, in the news more recently, particularly that women often feel that they haven't been listened to or that they haven't really had all the options explained to them and their respective risks and complications. So I think this is really just a reminder to understand the woman's perspective in all of this and to share that decision making with them. The third quality statement is around initiating medical management. So it says that a woman presenting with heavy menstrual bleeding is offered medical management, taking into account evidence-based guidelines, her individual needs and preferences, and any associated symptoms. Oral treatment should be offered at the first presentation when clinically appropriate, including when a woman is undergoing further investigation or waiting for other treatment. So I guess this is just a reminder for everybody that we can initiate treatment at that first appointment, even if we're not entirely sure what might be underlying or being the cause of the bleeding, and that there are many good medical options for treatment, particularly if the woman has mild or moderate heavy menstrual bleeding. And then the fourth quality statement is around quality ultrasound. So if a woman requires an ultrasound to investigate the cause of her heavy menstrual bleeding, that she's offered a pelvic, preferably transvaginal ultrasound, which assesses all pelvic structures, including the uterus and endometrium. And just a reminder that it's ideally performed on day 5 to 7 of her menstrual cycle, because that helps to better visualize the endometrium in particular. So yeah, that's just worthwhile putting on the request form and letting the woman know about when we make that request as well.
All right. Phoebe's mentioned already that the 52 milligram levonorgestrel intrauterine device is the most effective medical treatment for heavy menstrual bleeding. And this is the subject of quality statement 5. So it says, when medical management options are being considered, a woman is offered the 52 milligram levonorgestrel releasing intrauterine device if clinically appropriate, as it is currently the most effective method option for managing heavy menstrual bleeding. There are obviously some challenges with that. For example, many women may find a pathway to access a clinician who can insert the device challenging, but we're hoping that, you know, there's increasing use and uptake and training in general practice so that these women can be managed at the primary care level. In terms of specialist referral, a woman with heavy menstrual bleeding is referred for early specialist review when there is a suspicion of malignancy or other significant pathology based on clinical assessment or ultrasound. Referral is also offered to a woman who has not responded to medical management. So while most women with heavy menstrual bleeding can be managed in primary care, they really need to be referred to a specialist for any where there's any suspicion of malignancy or significant pathology, or where they actually just not responded to medical management. In terms of quality statement 7, this is uterine preserving alternatives to hysterectomy. So the statement says, a woman who has heavy menstrual bleeding of benign causes, who's considering non-medical management, is offered uterine preserving procedures that may be suitable, such as endometrial ablation, uterine artery embolization, or surgical removal of local pathology. And she's supported to make an informed decision and is referred appropriately. So patients considering non-medical management, there are a number of procedures that can be considered, and these include endometrial ablation, myomectomy, hysteroscopic resection, and uterine artery embolization. Quality statement 8 is around hysterectomy, and really just states that hysterectomy for management of heavy menstrual bleeding is considered when other treatment options are ineffective or unsuitable, or at the woman's request. A woman considering hysterectomy, though, needs to be fully informed about the potential benefits of the risks of the procedure before making a decision. And it reinforces this statement, the importance of considering less invasive options first, and ensuring that that women understand the benefits, risks, and consequences of the procedure.
Beautiful, thank you. So I guess the idea there is that it's appropriate option for some women, but we really should be considering other options first. Yeah, fantastic. Thank you. So now we're going to be going into talking about meeting these three women and talking through their situations and thinking through what might be suitable options for treatment of their heavy menstrual bleeding. Yeah, Kirsten, did you want to?
Yeah, so let's introduce our first case study, who's Sarah. She's 38 years old and she lives in rural New South Wales. She's seen another GP twice for heavy menstrual bleeding in the last 12 months, and she'd been advised that her heavy menstrual bleeding was normal. However, she feels tired and it's impacting on her relationships and her work. So I guess, Phoebe, as a GP, what's your approach to the initial assessment of this woman?
Yeah, so I think meeting Sarah for the first time, it is interesting to hear that she's seen another GP twice recently for this. So it makes me wonder, has she had any previous investigation? Has she already tried some previous treatment? Has there been some sort of breakdown perhaps in their therapeutic relationship? Or has there been escalation of her symptoms over the last 12 months? So when we talk to her about those things, we find out that Sarah is otherwise pretty well. She doesn't have any past medical history of note. She's been in a new relationship for the last 2 years, and she's using condoms with that partner. She has one child, and so she's open to the possibility of future pregnancies. She has a regular cycle with no intermenstrual bleeding or postcoital bleeding. Her periods are pretty long and heavy. They're lasting 8 days with a lot of clots and flooding as well. And for the first 1 or 2 days of the period, she says that she's getting quite a bit of pain. She's not a smoker. Her BMI is 31. She seems to look a little bit pale when you look at her. And then with the bimanual examination, that appears normal. And she's overdue for her CST. So we do a speculum examination and the cervix looks normal. So I guess for me as a GP, I would, provided that she hasn't had any of these things done in the last 12 months with the other GP, I'd organise for her to have a full blood count, ferritin, looking for iron deficiency, a transvaginal ultrasound on day 5 to 10, as we've talked about. And as we said, I think it'd be appropriate to start her on tranexamic acid straight away. So that's really giving her those instructions about using tranexamic acid during her period, and that she can expect to see significant improvement in the heaviness of her bleeding when she's using that. So Sarah comes back to see us, say a month later, and we see that she's not anemic, but she is iron deficient. And so we start her on some oral iron. Her transvaginal ultrasound was normal. And she says the tranexamic acid seemed to help a tiny bit, but not significantly enough that she feels that it's really doing the trick. And so she's definitely today wanting to explore other options for treatment. Yeah, so I guess in terms of thinking through what might be suitable for Sarah as next steps, there's quite a few options that we could talk about. The first is that the tranexamic acid seemed to work somewhat, so we could add in an NSAID, and that can be used very safely and used similarly during her period. We could also look at the combined oral contraceptive pill. Another option would be the intrauterine device or system. So I think another option, which is probably going to be less effective and we wouldn't use as first line, would be cyclic norethistérone. So that's something that we could look at using for day 5 to 26. But as a GP, I'd certainly be encouraging her to consider one of those other options. She tells us when we talk that through that she's tried the pill in the past, but she actually felt really moody on it and she's not really keen to do that again. And so she says that she's interested in using the intrauterine device, the levoregistral releasing system, and luckily there's another GP within the practice who inserts those regularly, and so we can make a sort of do a warm referral within the practice, and we'll see her back for review in 6 weeks' time after that. So she's happy with that plan. And I guess the benefit of that is that it also is a contraceptive. And it sounds like that's
right.
something that she's looking for at the moment, maybe not the future, but, you know, I always talk about how that's readily reversed with removal. So then let's meet Saba, who's our next case study. She's a 42-year-old woman who's had 3 children already, and she doesn't really plan to have any more children. She's married and she's using the withdrawal method for contraception, which she feels is working well. The last 2 years, though, she's really had heavy menstrual bleeding that just seems to be getting worse and worse. So she's passing clots, she's having flooding, she's having to get up in the middle of the night to change pads, and she's finding that it's really impacting on her quality of life. So for the first few days of her period, she's really having to stay at home as much as she can. The periods themselves are lasting, 6 to 7 days, so quite long too, but her cycle itself is still regular with no intermenstrual bleeding or postcoital bleeding. The examination, again, is quite unremarkable, and so we take a very similar approach to the previous case study, send her off for some initial investigations, and with Saba, we initiate Horan and NSAID just as something to try and see if that improves her symptoms at all before she comes back to see us. So when she comes back to see us, we can see that, yes, she is anemic and she's quite iron deficient. The transvaginal ultrasound shows 3 small fibroids, so that's probably part of what's causing her heavy menstrual bleeding, and perhaps they're getting bigger, which is why the bleeding's getting worse. But what's really interesting is that Saba, having found out that she's anemic and that she's got some fibroids, is requesting that she has a hysterectomy, as she really doesn't like the idea of being on any hormones to manage her symptoms. I actually see this fairly often, that women feel as though once they have tried the oral contraceptive pill or they don't want to be on it, that the next option after that would be a hysterectomy. How do we address that with a woman like Saba?
Yeah, no, so that's really true, Phoebe. A lot of women may come along, they're not aware of the other options, the other non-medical options. So I think it would be really important to have a discussion about what are the possibilities for management. Her fibroids are actually very small, and given they're intramural, they're unlikely to be the primary reason for her heavy menstrual bleeding. They're not impinging on the cavity, unlikely. So I think that, it would be important to discuss, non-medical options. She doesn't want hormones, but if you potentially explain that, the levonorgestrel intrauterine device involved local release of hormones, she might be open to that option. I guess there's the other non-medical options, including uterine artery embolization or endometrial ablation. You might consider, obviously, you want to exclude any pathological cause at the endometrial level. So I think it would be, having a discussion. Hysterectomy is a major procedure, and there are a range of kind of less invasive options that, she may consider.
Yeah, thanks, Kirsten. I think if we take the time to talk through all of those options, then often women are more open to thinking about those possibilities.
Yeah.
So for me as a GP, I'd be wanting to refer her to see a specialist to discuss all those options in more detail, but I might also consider adding on tranexamic acid to the NSAIDs that she's already using, and those two can be used together safely. And of course, we need to address her iron deficiency anemia while she's waiting to see the specialist. So we probably would start with just oral iron, but depending on how well she tolerates that and whether her anemia is improving, we could consider intravenous replacement as well. We referred her to a gynecologist. Just to let you know that one of the supporting materials for the heavy menstrual bleeding clinical care standard is a patient information sheet that you can see on the right-hand side here. And we might want to print that out for Saba to have a read through and think through those options as she waits to see the specialist. And it might help her to think through some of those questions that she might want to ask and discuss with the specialist. So she sees the specialist and they talk through all those things that Kirsten's just discussed with us. And she's quite interested in trying endometrial ablation. So organises to have that done. All right, and then we have our last patient. Her name's Suzanne, and she's a 46-year-old who has had a tubal ligation at the age of 35. So she's made a decision quite a long time ago that she doesn't want any children. She's got no current partner, but really she comes to see us because her heavy menstrual bleeding is quite significant. She's having 10 days within a 26-day cycle. And she reports not just heavy menstrual bleeding, but also symptoms of pelvic pressure, including urinary frequency. Her BMI is 25. She looks a little bit pale, a little bit anemic. And on bimanual examination, she has a bulky uterus. So we measure it at about 12-week size with some mild tenderness on examination. Again, we do all those same investigations we've done for the other women. And start some tranexamic acid while waiting for Suzanne to have the ultrasound. When she comes back to see us with the results, we can see that she has iron deficiency anemia, and the transvaginal ultrasound shows multiple fibroids and importantly, one very large intramural fibroid that's 11 centimetres. And so we are going to refer her also to talk to a gynecologist about her options. What are those options, Kirsten, that Suzanne might be presented with?
Yeah, so Suzanne's got multiple fibroids. They're very large. They're causing symptoms. So you could offer her uterine artery embolization, and certainly you would anticipate that you would get, more than 50% reduction in the size of the fibroids, but noting that it will take potentially, 3 to 6 months to have a full effect, potentially. Myomectomy is a very kind of bloody procedure, and where you've got multiple fibroids, it's probably not recommended here, and particularly in someone who doesn't wish to retain their fertility. Generally, if you've got very large fibroids that are causing pressure symptoms, hysterectomy may be a good option. So I think that you would particularly discuss uterine artery embolization with her, but also you would discuss hysterectomy.
Thanks, Kirsten. It really just does sound like those other earlier options, those medical options that we consider for the other two wouldn't be appropriate.
That's right. Once the fibroid's grown to a very large size, you probably need, the better non-medical options or hysterectomy.
Yeah, great. Thanks, Kirsten. All right. So that brings us to the end of today's presentation. I just want to let you know about what these resources look like if you'd like to learn more about heavy menstrual bleeding and what good quality care looks like for either yourself or the service that you work within. So on the left side is the clinical care standard itself. It's got a lot of detailed information for consumers and for clinicians and for health services. In the middle, we've got a range of fact sheets, both for clinicians and consumers, that really just walk through each of those quality statements. And then the consumer information sheet we've already talked about there. And hopefully these can support you to provide really great care for your patients. So as we finish up, just to talk through the key messages from today's discussion, we know that heavy menstrual bleeding significantly impacts the lives of many women across Australia, and we do know that many aren't receiving timely or appropriate treatment. And so what's really important here is quality care, which starts with good assessment, physical examination, and appropriate investigations. It's really important for women to be offered tranexamic acid or NSAIDs as appropriate from the first presentation to manage those symptoms and limit further impact. And then when we think about actual treatment for their heavy menstrual bleeding, it's always important to consider less invasive treatment option before hysterectomy, acknowledging that some women will require a hysterectomy. And if you'd like further information, as we've talked about, do refer to the Clinical Care Standard and related resources. So thank you so much, Kirsten, for joining us today. It's been really good to talk to you about that and learning from you. And thank you. And always hop on our website. That's where all those resources are. All right. Thank you then.